So this is the common neurological disease that you encounter, and you do get this in your exams. So by definition, the definition of stroke is an acute onset or a rapidly progressing. So it's an acute onset of disease. So it's an acute disease, and it could be a focal neurological deficit. Very rarely stroke can produce a global deficit. And the etiology for stroke is vascular. So when we talk about the etiology of stroke, it is vascular. So when we mean stroke, it's an acute onset of a focal neurological deficit that can be due to a vascular etiology. So when you see the WHO definition, the WHO, when it defines stroke, it says that it is a focal neurological deficit that cannot be attributed to anything other than vascular. So they do not use it as vascular. They say it cannot be anything other than vascular, that is called as stroke. So by meaning, when we have a stroke, we are dealing with a basic problem in the vascular problems in the central nervous system that we're talking. So it's a UMN disease we are talking. It can affect various parts of the brain. It can affect the cortex. It can affect the subcortical regions. It can affect the brain stem, and also the spinal cord also can get involved in stroke. But the classical discussion, when we go on to a stroke, when we are discussing, we are basically discussing about hemiplegia. So this is the case that is usually kept for you in the exam, hemiplegia. So they keep a case with hemiplegia, and you are expected to do the evaluation, take a good history, and do an examination, and come about to what is the cause for hemiplegia and why this structural abnormality has occurred in this patient. So whenever we give a neurological case, the two questions that are always to be answered is, one is the nature of illness, what is the nature of the disease, and second is the site of illness or the site of lesion. So these are the two things that we have to arrive when we take a history and examine. And please remember, in nervous system examination or nervous system history, good history can give you a 90% diagnosis. You have to just do an examination to confirm your diagnosis. So a good history would give you the diagnosis. In almost complete diagnosis can be given. So when we mean by the nature of the illness, as we said, the cerebrovascular accident is always going to be a vascular etiology. So the problem is in the vessel. So the two types of problems can happen. So it could be either due to ischemia, or it could be due to a hemorrhage. So it could be due to an ischemic stroke or a hemorrhagic stroke. By far, the large amount of strokes that we have are ischemic strokes only. So if you go on to the etiology of ischemia, the basic two categories that could come under ischemic stroke, either you have a thrombotic stroke or you have an embolic stroke. So these are the two etiologies that come under the ischemic stroke. The hemorrhagic strokes basically are the intracerebral hemorrhages. So these are the three varieties of stroke. If you say a natural stroke which we are seeing in elderly, if you see the ratios of these three diseases, the thrombotic strokes is 8 times more common, embolic, and the hemorrhage is 1 time that common. So if you take 10 strokes, if you see the ratio is 8:1:1. So thrombotic strokes by far is the commonest stroke that you would get as you go in the elderly. But if you see a younger patient, we call it a stroke in young. Stroke in young is whenever the stroke is less than 45 years of age. If you see the ratio in such patients, the most common stroke that you get in young strokes is embolic strokes. That's almost 4 times there. Thrombotic strokes would be second, followed by hemorrhagic stroke. So the ratio changes there. So it's not only important for us to just know about the thrombotic strokes. With the advent of a lot of diseases, metabolic diseases that have come, your young strokes are becoming more and more common. So we have to also consider these two other etiologies of stroke. So to know the etiology of stroke or the nature of illness, the most important thing that would come into is the history itself. So you should have a good enough history, and based on that history, you will be able to get a reasonable diagnosis about what is the nature of illness. So when we say the nature of illness, it's a whole class on itself when we take the nature of illness. But I think in today's session, since we are discussing localization, I will briefly touch about how do you assess the nature. So the first question that you're going to ask is timing of the stroke. So what time did the stroke happen? That's the first question. The second question is deficit at onset. Deficit at onset. And the third important question is progression of deficit. So these are the three questions that you have to very, very carefully concentrate on in your history, which will help you to localize the type of stroke that you have. So if you take the thrombotic strokes, if you see the thrombotic strokes occur early morning. So 4 a.m. is the time when thrombotic strokes happen. Now, why does this happen? Why the blood is more prothrombotic at 4 a.m. in the morning? Remember, hypercoagulability is what makes it. And we have various factors. The main factor that you have is something called as a plasminogen activator inhibitor, the levels of which govern the stroke happening. So that is the reason why all thrombotic event, be it thrombotic stroke, be it thrombotic MI, or any other thrombosis occurs at 4 o'clock in the morning. So the thrombotic strokes, the patient will wake up with the stroke. That's very important you have to remember. Whereas the embolic stroke and the hemorrhagic stroke both occur during activity. So both embolic as well as the hemorrhagic stroke, there is activity that is needed. Only with the activity it will come. So they don't occur at sleep. So that's the first question that you have to ask. When did the stroke occur? What was the patient doing? So if he was doing something and all of a sudden the stroke has happened, so it's more likely to be an embolic or hemorrhagic stroke. But yes, if the patient woke up with a neurological weakness, then it's more likely to be a thrombotic stroke. You're most often right based on the timing. Second important part you have to ask in history is the deficit at onset. Now remember, embolic stroke, the deficit is maximum at onset. So the patient gets a deficit, that will be the maximum at onset. So the deficit will be maximum. If they have a hemiparesis or a hemiplegia, they have it maximum at onset. There is no progression of deficit. Whereas in contrast, in thrombotic strokes, there is a nice stepwise progression of stroke. What we call it as a stroke in progression. I think the pathophysiology you would have known, there is an ischemic core, surrounding which we have a ischemic penumbra, and that gets affected. That's why the deficit progresses. So there is a progression of deficit which is very characteristically seen in case of thrombotic stroke, because the region, that is the ischemic penumbra which is surrounding, that also gets involved. What happens in hemorrhagic? Remember, when blood comes out of the vessel, it produces a lot of edema. So whenever there is so much of edema that's happening, again the deficit will progress. Okay. So remember, the deficit is maximum at onset in embolic stroke. So based on these two questions, you can make out what type of stroke it is. So supposedly a patient has woken up in the morning and he says he went to the washroom, he was having slight weakness there, then he came back and slept. By the time he woke up again, he had more weakness. By another 1 hour, he had facial weakness there. And by another 2 hours, the patient had complete hemiplegia and he was not able to walk. So that is the classical thrombotic stroke. Whereas if a patient was doing a work and all of a sudden he falls and then he has complete weakness on one side, complete loss of weakness, that is embolic stroke. So that occurs during activity. Hemorrhagic stroke, the other important feature which almost always is there are signs of raised intracranial tension. Patient can have headache, patient can have projectile vomiting that could be there. So that, if it is there, would suggest more of a hemorrhagic stroke. But please remember, the raised intracranial tension can also occur when you have a large ischemic region. So it's not specific for hemorrhagic stroke, but yes, if it is there in a patient, then it's more likely to be a hemorrhagic stroke. The other important factor that you have to always remember when you tell the type of stroke is the risk factors. So based on the risk factors, you can localize what type of stroke or what type of stroke that we are having. Now, supposedly we are talking about the commonest stroke, that's a thrombotic stroke. So most important non-modifiable risk factor, age and male gender. So these are two important non-modifiable risk factors that you have for thrombotic stroke. So thrombotic strokes, this is the important thing. The other important risk factor for thrombosis, please remember, hypertension. Again, a very common question they ask you is hypertension. What type of strokes do you get? Remember, the most common type of stroke in hypertensives is thrombotics. 95% of the strokes in hypertensive is thrombotics. But yes, please remember, hemorrhagic strokes are almost always seen in hypertensives. But the most common type of stroke that you get in hypertensives is thrombotic. The other important risk factors for thrombosis: diabetes, if the patient has dyslipidemia, if the patient has smoking, alcohol, postmenopausal females are the risk factors for that. If a young patient is getting thrombosis, supposedly he is less than 45 years and he is developing thrombosis, that's when you have to consider a prothrombotic state. Anybody in the chat can answer what are the common prothrombotic states that we have? People can unmute and answer. Is it possible?
Yes, sir, it's possible, sir.
Anybody, one of you can unmute and answer. Because
So pregnancy.
okay, pregnancy, yes. Okay, pregnancy is a prothrombotic state. But more important, when we talk about prothrombotic, we don't say something physiological. Pregnancy is physiological. Any other prothrombotic?
Antiphospholipid antibody
Thrombophilia.
syndrome.
Okay, so antiphospholipid antibody syndrome, thrombophilias, as you said, there are thrombophilias where you have deficiencies of certain factors.
OCP pills.
Yes, OCP pills is correct. Remember the polycythemia. Polycythemia is an important risk factor. Leukemias are important risk factors. And again, remember there are inflammation of the vessel can happen. What we call it as the vasculitis. Okay, vasculitis could occur either primarily due to a vasculitis disorder, or more importantly, we have two infections that are common in our part which produce vasculitis. Anybody? What are those two infections where you have vasculitis?
Syphilis.
Syphilis is the disease of the past. We don't see it now that often.
Hepatitis B and C.
No, that is common. I do agree. Two important diseases which produce a stroke.
Silly.
Infections. I was talking about two infections.
Polyarteritis nodosa.
That
And
is a connective.
vaginals.
That is a connective tissue disorder. We are talking about infections which produce vasculitis.
Okay. HIV.
HIV. Please remember HIV and tuberculosis. These are two common infections. Again, we see it very often. Both of these infections can produce. Okay. Both of these infections produce vasculitis and they produce strokes. So when you see a thrombotic stroke in a young patient, we have to think of prothrombotic states. So get the blood counts and then see if there is polycythemia, thrombocytosis, etc. And a very common disorder, especially in India, what you get is related to an amino acid. Anybody can tell me?
Hyperhomocystinuria.
Yes, very important. Hyperhomocystinemia. And also remember, it's common in pure vegetarians because vitamin B12 deficiency produces hyperhomocystinemia. So these are the causes of thrombosis. So these are the risk factors that you'll assess for whenever there is thrombosis. Now, if you come to the second etiology which we discussed is embolism. So embolism, the clot has to arise from somewhere and go. So the two important sites it can arise from, one is the heart, called as the cardioembolism, and the second more often is from the vessels itself, called as atheroembolism. So from a large vessel, carotid or the aorta, arising the clot or the plaque which can dislodge and it can go and cause embolic strokes. So again, remember, in young patients, it is more often cardioembolism that we're looking for, whereas in patients who are older part of it, you can see it is more of atheroembolism. So older patients get atheroembolism, whereas younger patients do get cardioembolism. So younger patients, you would most importantly ask for history of rheumatic heart disease, or you can ask for histories of atrial fibrillation. And please remember, the most important cause of cardioembolism is atrial fibrillation. So you will have to take history of that in the patient. So young patient, embolic stroke, cardioembolism. Elder patient, embolic stroke is atheroembolism. The third type of stroke is hemorrhagic strokes. Again, remember, hemorrhage can occur in younger patients, can occur in older patients. Older patients, the most important etiology is hypertension, uncontrolled hypertension. Please remember, not any hypertension. Remember, hypertension, I told you, is the most important risk factor for thrombosis. But when you have an uncontrolled hypertension, that's where you can get hemorrhage. Also, you have elderly patients can have one more common disease in elderly which can produce hemorrhage? Anyone can tell me? Which is the other disease we get if a 85-year-old person comes with hemorrhage? Aneurysms are common in young patients, not elderly.
Subdural hematoma.
Subdural hematoma is not it produces symptoms like stroke, but that doesn't classify as stroke. We don't call it a stroke. Which is the other disease which happens as you age, which is the other degeneration that happens in the vessels, which can make them bleed.
Hyaline degeneration of the
Hyaline degeneration, okay. Okay, it's something like hyaline degeneration, what we call it as an amyloid angiopathy. So remember, hypertension and amyloid angiopathy are the two important diseases which occur in elderly, which produces hemorrhage. So one thing that you have to always remember is hypertension never produces hemorrhages into the lobes. Please remember, hypertension produces hemorrhages at various sites, but it does not produce hemorrhages in the various lobes. The most common site of hypertensive bleed is the basal ganglia. So it goes to the basal ganglia. It can go to the putamen as the commonest site there. It can go to the pons. It goes to the thalamus and cerebellum. So 90% of hypertensive bleeds occur at this site. It never comes to the lobe. Okay, very, very rarely you can get lobar hemorrhages. But in contrast, amyloid causes lobar hemorrhage. Lobar hemorrhage. So this is what you have to remember for hemorrhage in elderly persons. You can get aneurysms, okay, but again remember the aneurysms. Where are the aneurysms located? Where are the aneurysms located?
Circle of Willis.
Circle of Willis. So where is the circle of Willis located? Inside the brain or outside?
Inside.
Outside.
Outside.
It's in the base, na? It is not inside the substance of the brain. So if there is an aneurysmal bleed, what type of hemorrhage do you produce? What type of hemorrhage? It produces subarachnoid hemorrhage. Okay, it doesn't produce intracerebral hemorrhage. It produces subarachnoid hemorrhage. If you see younger patients coming with hemorrhage, the most important etiology in young patients which produce hemorrhage are AV malformations. Okay, AV malformations are the most common etiology of hemorrhage in young patients. Also remember, patients who are on antiplatelets, anticoagulants, and certain other drugs can produce hemorrhage. So these are the risk factors that we have to understand. So what we discussed so far is to get to the nature of the illness. So to see what is the disease that we are talking about, the nature of the illness is governed by a good history and the risk factor analysis. Hope I'm clear so far. So take a good history. The two important questions which I told you is the timing of the onset of the neurological weakness the patient is having. Second is what is the progression, whether there is maximum at onset or it does progress. Next is the risk factor analysis. So based on these two things, you can make out whether we are dealing with thrombosis, we are dealing with embolism, or we are dealing with a hemorrhage. Next, the most important part and the point of today's discussion that we are discussing, that is the localization, or where is the disease we are talking about. So localization of stroke, or what we call it as the site of lesion. So as we discussed hemiplegia, we are talking about hemiplegia only in today's discussion. I'm not going to describe the other neurological problems. I'm going to discuss only about hemiplegia. By meaning, the word hemiplegia means there is involvement of the upper limb and lower limb on one side of the body. On one side of the body, that is hemiplegia. What do you mean by hemiparesis? And what do you mean by hemiplegia? Hemiplegia means the power is 0 by 5, whereas hemiparesis means it is not 5 by 5, so it is lesser than, it might be 4, it can be 3, it can be 2, but it is not 0. So when you say hemiplegia, it is complete paralysis, and when we say hemiparesis, it means a partial weakness, but it is one side of the body. That is what you have to remember. The next term that you have to remember whenever we discuss hemiplegia is the term what we call as dense hemiplegia. Now this is a very important term that you have to understand. What do you mean by dense hemiplegia? Anybody can tell me what is dense hemiplegia?
Both upper limb and lower limb weakness.
That is there in any hemiplegia, na?
Same grade of weakness in both upper limb and lower limb.
Equal weakness in upper limb
Okay,
and lower limb.
equal weakness, very important. So dense hemiplegia means upper limb is equivalent to lower limb. So the power of upper limb and the lower limb is equally involvement. That's when we call it as dense. Hemiplegia means 0. So both are 0 by 5 power. That when we say dense hemiplegia. You can say dense hemiparesis if it is 3 by 5 or in both upper limb and lower limb. If supposedly the upper limb is 3 by 5 but the lower limb is 0 by 5, this is not dense. Where the upper limb is less involved and the lower limb is more involved. That does not become dense. So when we say dense, it means upper limb and lower limb are equally involved. Now, what's the importance for us to understand whether it is dense hemiplegia or not? Please remember, dense hemiplegia always means internal capsule involvement. Now, why does internal capsule involvement produce dense hemiplegia? Please remember, internal capsule is a very small area that's there, and the entire corticospinal tract, which supplies the entire one half of the body, is located in that very small area. So it's a very small area, and at the genu and the posterior limb of the internal capsule, the pyramidal tract is one which is going to go down, and that small area, all the fibers are there. So that is, if that part is involved, both the upper limb and lower limb will get involved equally, and that is what we call it as dense hemiplegia. So dense hemiplegia is pathognomonic of internal capsule lesion. Okay, internal capsule lesion is the one which produces dense hemiplegia. All other sites of lesions do not produce dense hemiplegia. Sometimes you could have upper limb which is more involved. Sometimes you can have lower limb that is more involved. If upper limb is more involved, we call it as brachial hemiplegia. So brachial hemiplegia means we have a hemiplegia, but the upper limb is more involved than the lower limb. Whereas if the lower limb is more involved than the upper limb, we call it as crural hemiplegia. Okay, so if the upper limb is more involved, we call it as brachial, and if the lower limb is more involved, we call it as crural hemiplegia. So that's the first term that we have to understand, that is what is dense hemiplegia and what is not dense hemiplegia. The next point that you have to understand is what is crossed hemiplegia. Sorry. What is crossed hemiplegia and what is uncrossed hemiplegia? Yes, anybody can tell me?
When lower level of pons is involved, then it is a crossed hemiplegia. If it is above that, then it is a.
Now, what do you mean by crossed? The site of lesion, I agree, it's in the not in the pons, it's below the medulla.
Ipsilateral facial and contralateral weakness of the lower.
It's not
Upper limb and
necessarily
lower limb.
facial. It's not necessarily facial. So remember the pyramidal tract. If you see, the pyramidal tract is arising from the cortex, and from there the pyramidal tract comes down. It goes through the internal capsule, goes to the midbrain pons. At the lower part of the medulla, it's going to decussate and go to the opposite side. So supposedly you have a lesion on this side, on the right side. I'm talking here. The hemiplegia will always be on the left side. So you have one-sided involvement. The lesion will be, the hemiplegia will be on the opposite side. But supposedly if you have a lesion below the decussation, okay, you have a lesion below the decussation, you will have hemiplegia on the same side. So left-sided lesion, left-sided hemiplegia. Now you have the cranial nerves. So you have various cranial nerves that are there. So supposedly we can take an example of one of the cranial nerves, like third cranial nerve. So supposedly if I say third cranial nerve, it's located somewhere in the midbrain here. You have the 12th cranial nerve that's located in the medulla there. So supposedly you have a lesion above the decussation, So decussation is here. The cranial nerve will be on one side, the hemiplegia will be on the opposite side. But if you have a lesion below the decussation, that's specifically for the 12th nerve, the cranial nerve and the hemiplegia will be on the same side. So the word crossed and uncrossed basically refers to the decussation. So if you have a lesion above the decussation, you do get crossed hemiplegia. If you have a lesion below the decussation, you get uncrossed hemiplegia. So these are some of words that you have to remember. Supposedly, sometimes in the MCQs or sometimes if you answer well, they'll ask you if if you have a lesion at the decussation, what sort of hemiplegia do you get? Please repeat. Okay. So, okay, you want me to repeat what is crossed and uncrossed? Okay. So, okay, let me draw the pyramidal tract for you. So, here is the right-sided cortex, here is the left-sided cortex, and here the pyramidal tract is arising from the cortex. Okay, and there the pyramidal tract enters through the internal capsule, and there it goes down to the corticospinal tract. It goes through the midbrain, it goes to the pons and comes to the medulla. At the lower part of the medulla, it is going to decussate and go to the opposite side. Is that clear so far? Okay, so if you have a lesion above here, supposedly I have a lesion here. So if I have a lesion here on the right side, if I'm taking a lesion there, the hemiplegia will be on the left side because the decussation is here. But supposedly I take a lesion here in the lower part of the medulla here after the decussation. Left-sided lesion will produce left-sided hemiplegia, whereas right-sided lesion will produce right-sided hemiplegia. Is that much clear so far? Okay. Now coming on to the cranial nerves that are there. Now supposedly you have the various cranial nerves. You know that the third and fourth cranial nerves are located in the midbrain. The 5, 6, 7, 8 are located in the pons. The 9, 10, 11, 12 are located in the medulla. So this is the cranial nerves that is arranged. So supposedly I take a lesion at the midbrain. Okay, I'm taking a lesion in the right-sided midbrain. So what happens? The right-sided cranial nerve getting involved. So the cranial nerve is on the right side. Which side is the hemiplegia? It's not yet crossed. So the hemiplegia is on the left side. Is it clear? So cranial nerve is on one side, hemiplegia is on the opposite side. Now, if I take a lower part of the medulla where the decussation has already occurred, the most common cranial nerve that's located is the 12th cranial nerve there. Now, if I take the lesion and this side, so I'm saying a right-sided lesion I'm taking here. So already decussation has happened there. So the hemiplegia will be on the right side. The cranial nerve also, 12th cranial nerve is also on the right side. So this is uncrossed hemiplegia and this is crossed hemiplegia. So above the decussation, you have cranial nerve on one side and hemiplegia on the opposite side, whereas below the decussation, if at all, you'll have the hemiplegia and the cranial nerve on the same side. That's what we call it as crossed and uncrossed. It's basically for the brainstem only, because crossing we know occurs at the brainstem. So all your internal capsule, cortical lesions, all are uncrossed, all are crossed hemiplegias only. Only the brainstem lesions can be crossed or uncrossed. If it is crossed, that means it's above the decussation. If it is uncrossed, it becomes below the decussations. Hope I'm clear. The question that I'd asked, I think somebody answered in the chat. What do you get if you have a lesion at the decussation? So if you have a lesion at the decussation, what you get is something called as a cruciate hemiplegia. So cruciate hemiplegia is the one you get at the decussation. You get one-sided upper limb, the opposite side lower limb. So if you have a right-sided upper limb, the left lower limb will be involved. So it's like a cross. That's because of the fiber arrangement. So that's a question that's asked. If supposedly you answer all questions, they ask you what do you get that. So you get cruciate hemiplegia at the site of decussation. It's rare to get that because generally you get quadriplegia at that site. So the terms that we have described so far, we described what is hemiplegia, what is hemiparesis, then we described what is dense hemiplegia, then we described what is brachial hemiplegia, then we described what is crural hemiplegia, and then we described about the term that is crossed or uncrossed hemiplegia. Hope I am clear so far. Okay, we'll proceed. Now coming on to hemiplegia and its localization. So when we say hemiplegia, when a patient of stroke is given to you, what are the sites of hemiplegia that you could have? So hemiplegia can occur at various sites. Okay, the first and the most common site that we encounter hemiplegia is internal capsule. So internal capsule is the commonest site of hemiplegia that you have. The second site is above the internal capsule, what we call it as the cortex. The third site could be in between the internal capsule and the cortex, what we call it as a subcortex. The next site are the brainstem. So in the brainstem, you have three important sites, that is the midbrain, the pons, and the medulla. So the midbrain, pons, and medulla. And the last site is the spinal cord, the cervical spinal cord above C4. Now let's understand this a little more. Remember, internal capsule is the most common site, followed by the cortex, then the subcortex, midbrain, pons, medulla. These together form the brainstem. So these are the sites of hemiplegia. Okay, if there is hemiplegia, it has to be one of these sites. Okay, why do I say cervical spinal cord? Why can't a thoracic or lumbar spinal cord cause it? Because remember, the upper limb fibers are given. What is the upper limb topmost root value? Deltoid is C5, so above that. So C4 is where the upper limb fibers are given. So supposedly the upper limb fibers are given already. If the upper limb fibers are given, after that you can't get hemiplegia, you can only get lower limb weakness. So you can get hemiplegia in the spinal cord disease if the level is in the cervical cord above C4. So these are the sites of hemiplegia that you can get in your exam. So what we have to understand is how do we localize each of these sites of hemiplegia. Okay. So before we go on to that, just remember the internal capsule, the cortex and subcortex belongs to something called as an anterior circulation. Anterior circulation. What do you mean by anterior circulation? Anterior circulation stands for what vessel? Anterior circulation is the carotid and its branches. So the internal capsule, cortex and subcortex belongs to anterior circulation, the carotid circulation, whereas the brainstem and the spinal cord belong to your posterior circulation, which is nothing but vertebrobasilar. So vertebrobasilar, this is what you have to understand. Yes, so carotid circulation includes both ACA and MCA, whereas basilar includes the vertebral, the basilar that's coming, and the branches of that. So let's move further and we'll try to localize and tell what are the features of each of these strokes that we could get. So before we go on to that, we should know the functional anatomy of the nervous system or how the fibers are arranged. So let's briefly discuss that now. So as we discussed, all your pyramidal tract is going to start from the cortex. So this is the cortex I'm drawing here. So this is the midline. So this is the cortex. So the bed cells, the postcentral gyrus where is there, your motor homunculus there. From the bed cells, the pyramidal tract is going to originate. So the pyramidal tract is going to originate from there, from all these tracts here, coming down as the corona radiata, and it converges onto the internal capsule. So that's the most important site that we have. So that's the internal capsule. So these fibers are going to converge at the genu and the posterior limb of the internal capsule. From there, it's going to form the pyramidal tract and it's going to come down medially. It comes down through the midbrain. Then it's going to come down through the pons. And then it's going to come down through the medulla. So it's going to come down medially from the midbrain, the pons, the medulla, and the lower part of the medulla. That's where it's going to cross over and go to the opposite side, spinal cord. It's going to form the anterolateral corticospinal tract. So this is how our pyramidal tract is originating. So you have the pyramidal tract on both sides. You have it on the right as well as you're having it on the left. So if I can draw the left sided, pyramidal tract also would come like that and go down, decussate here and go to the spinal cord. So this is how the pyramidal tract is getting involved. So we can have a lesion anywhere starting from the cortex here. The next important site we have discussed is the internal capsule. That's the second site that we have. Between the internal capsule and the cortex, you have the subcortex as a site. You can have a lesion in the midbrain, the pons, the medulla, and the cervical spinal cord above C4. So these are the sites where you can get hemiplegia. So how do we localize each of these sites? Because hemiplegia is there in all the sites. So how do you localize each of these sites? Basically, it is by the company the hemiplegia keeps. So what is there along with the hemiplegia? So hemiplegia plus what else is there? That helps us to decide where is the site of lesion. Okay. So before we go on to actual localization, a little more brief on the anatomical part of it. You have the cranial nerves, as I think you would have learnt in your anatomy or in your neuroanatomy. There's something called as a rule of force. Anybody can tell me what is the rule of 4? For cranial nerves, you have something called as a rule of 4. So, anybody?
Origins of the
Based on the nerve supply. That is
First two from midbrain.
4,
second,
5, 6, 7, 8.
third and fourth from midbrain. 5, 6, 7, 8 from
Okay.
pons, and 8 and 10, 11, 12 from medulla.
Okay, so that's the one of the rules. So there are 4 rules of Gates described. 4 rules. 4 rules here is described. So the one is the cranial nerves. 4 originate from the pons, 4 above and 4 below. So the ones which are originating from the pons, as you have described it, 5, 6, 7 and 8. The ones which is arising from the medulla is 9, 10, 11 and 12. And the one which is arising from above, that is 3rd and 4th, will come from the midbrain. However, you have your 1 and 2 is direct communication. So there is no nucleus that is there for 1 and 2. 3 and 4 have their nucleus in the midbrain. So that's the first rule of Gates. The second rule of Gates is very important for us to localize the hemiplegia, because Gates, based on this rule only, we can make out where is the site of lesion. Of this cranial nerves, only 4 cranial nerve located medially. Remember in the diagram which we drew here for the pyramidal tract, we have drawn it here. You can see that the pyramidal tract is located medially in the brainstem. It's located medially. So only 4 cranial nerves are located medially. Which are the 4 cranial nerve nucleus which are located medially?
3, 6, 12.
Okay, one more.
And 4. And
Okay.
4.
And 4.
So 3, 4, 6 and 12.
Yeah.
Yeah, 3, 4, 6 and 12 are the 4 cranial nerves which are located medially. Okay, so what's the relevance of this? Anybody can tell me? What's the relevance of knowing that these are located medially?
Motor nuclei.
Yeah, this is the motor nuclei. The other motor nuclei are located laterally. Like you have 5, 6, 7, 8, 9, 10, 11. No? They are located laterally. 6 is not. Okay. What's the importance for us to know whether this is medially located or laterally located? Why do you have to be knowing that? How does it help? Anyone? Why do you have to know this? Okay, syndromes. Okay, it's important for us to know because we are talking about stroke, and stroke is a vascular disease. So stroke is a vascular disease we're talking about. So this medial part, the medial part of the brainstem is supplied by one blood vessel. The lateral part is supplied by one more vessel. So it's the different blood vessels that are there for different. So since the pyramidal tract is located in the middle, these cranial nerves are more likely to get involved with pyramidal tract. So supposedly I say a medial medullary syndrome. So if I say medial medullary syndrome, which cranial nerve do you expect to get involved? 12, yes. If I say it's a lateral pontine syndrome, which cranial nerves do you expect to get involved? 5 and 7 in the lateral part of the pontine syndrome. So that's why we have to know. So that's the second rule that we discussed. Is one is the 4 cranial nerves are located where they are located. Second is only 4 of the cranial nerves are located, which are located in the 4 cranial nerves are located in the medial part. The rest cranial nerves nucleus is located in laterally. So these are the two important 4s. There are 2 more rules of 4s. I'll come to that when we are discussing the brainstem. Okay. Now the next part before we go on to the cranial nerves, why cranial nerves are involved in stroke. So remember, each of these cranial nerves have the nucleus. Just a minute, I think so each cranial nerve has a nucleus there. So supposedly I'm talking about the 3rd cranial nerve. Where is the 3rd cranial nerve nucleus located? Where is the 3rd cranial nerve nucleus located?
Superior colliculus area.
No, which structure which we discussed so far? It's in the
Midbrain.
midbrain, isn't it? We're talking about the midbrain. So 3rd cranial nerve nucleus is located in the midbrain. So when we take the midbrain, 3rd cranial nerve nucleus will be located. So you have the right side 3rd cranial nerve nucleus and the left side 3rd cranial nerve that is there. Both these cranial nerves get corticonuclear fibers from both sides. You understand? The right-sided 3rd nerve nucleus gets the corticonuclear fibers from both right side and left side. So if you have a lesion above the midbrain, okay, if supposedly I have a lesion in the internal capsule, will this cranial nerve get involved? Will the cranial nerve get involved? Will you get a manifestation of the cranial nerve?
No, sir.
No, because it has bilateral representation. So the cranial nerves will get only manifest only if, okay, cranial nerves will get manifested only if you have bilateral corticonuclear involvement, if the involvement is on both sides, okay. If the involvement is on both sides, supposedly you get a lesion on the up here as well as up here, what we call it as a pseudobulbar palsy, or else the cranial nerve will only get involved if the cranial nerve nucleus gets involved. So supposedly we have a midbrain lesion. You have a classical syndrome called as Weber syndrome. We'll be discussing it, where the midbrain is involved. So there you will have a lesion which is there, and that can produce a lower motor neuron type of cranial nerve involvement. So all cranial nerves are not involved in stroke basically because of this reason. So cranial nerves are not involved because these cranial nerves have bilateral corticonuclear representation. The only exception for this, yeah, I'm trying to draw with the thicker pen, but I don't know, for some reason. Okay, now let's see. No, it's still becoming thin. Just give me a moment. Highlighter could be better. Okay, let's try the highlighter. Okay, but highlighter is in which color? Okay, it's black. So the only exception for this rule is the facial nerve. No, it's not coming. The facial nerve nucleus. Remember, the facial nerve nucleus is located in the pons. The facial nerve nucleus has 2 parts. You have an upper part and you have a lower part. So the upper part of the facial nerve nucleus gets supply from both sides. So the upper part of the facial nerve nucleus gets supply from up by right side as well as the left side, whereas the lower part of the facial nerve nucleus, which is there in the pons, gets supply from contralateral side. Please remember, not ipsilateral, contralateral side. Now, why do you have to know this? We have to know this because this upper part, if you see the face here, this is the representation of the face. The upper part of the facial nerve nucleus will supply the upper part of the face, that's still the eye, whereas the lower part of the facial nerve nucleus supplies the lower part of the face. Now, supposedly, we said this lower part of the facial nerve nucleus has only one-sided supply, that is from the opposite side. That is why in all strokes we get facial nerve palsy, because one part of the facial nerve nucleus, that's the lower part of the facial nerve nucleus, is getting only one-sided supply. Okay, so you get involvement of the lower part of the face. The upper part of the space is spared. The upper part of the face is spared. Now, why the upper part of the face is spared? Please remember, the nucleus which supplies the upper part of the face gets supply from both sides. That's why the upper part of the face is spared. Now, this type of paralysis where only the lower part of the face is involved is called as the upper motor neuron type of facial nerve palsy. So, upper motor neuron type of facial nerve palsy, by upper motor neuron type of facial nerve palsy, we mean it is a corticonuclear palsy that's happening. That is, it's not at the nuclear level, it is above the nucleus. So how do you identify a UMN facial palsy versus LMN facial palsy? In UMN facial palsy, the upper part of the face is spared. Okay, so upper part of the face is spared, only the lower part of the face gets involved. Only the lower part of the face is getting involved. And that is basically because of the upper part of the facial nerve nucleus is supplied bilaterally. So this is the exception. This is an exception. Similar to that, please remember, in the 12th nerve, you have genioglossus. Okay, 12th nerve nucleus. 12th nerve supplies various muscles of the tongue. There is one which supplies the genioglossus. So that also has similar pattern. Okay, that's why in most of the stroke patients, you will find slight deviation of the tongue because of that nucleus which is supplying to the genioglossus gets involved. But that's not a very important thing. Just remember about the facial nerve nucleus. That is the most important thing that you have to remember. So all cranial nerves get involved in stroke, but they do not manifest because they have bilateral corticonuclear representation. So that is what you have to understand. Facial nerve nucleus does not get that. Why the facial nerve is involved? Because the facial nerve nucleus, the lower part, has only one-sided, that is the contralateral supply. Okay, so after knowing this much, let's start with the localization of the stroke. The most common site of stroke that we encounter, is internal capsule. Now the question often asked is, why is internal capsule the most common site of stroke? Why is internal capsule the most common site of stroke? For some reason yes, anybody can answer me that? Why is internal capsule the most common site of stroke? Okay, some say that is end arteries, correct? That's one reason. End arteries, that's one reason for why it is. Internal capsule, please remember, internal capsule has a very wide blood supply. Okay, it's a very small area. It has multiple blood supplies that you have. So internal capsule is supplied by the middle cerebral artery. It is supplied by the anterior choroidal artery. It is supplied by the posterior communicating artery. So multiple blood supply is there, but still all these arteries are end arteries. So please remember, all of these arteries which supply the internal capsule are end arteries. So there is no anastomosis that's happening. So if any one of the arteries get involved, you do get internal capsule stroke. So internal capsule stroke is the commonest because of that reason. Okay, so what are the features that will be there in an internal capsule lesion? So we have already discussed the diagram that time, where we discussed how the pyramidal tract is arranged. I think here. Okay, so you're able to see that there. So you have the pyramidal tract that starts from one side and it's going here through the genu and posterior limb of the internal capsule, this part where it is getting going there. So here, if it gets involved, so what is the most important feature they'll have? So we have already discussed the first and most important feature they have is hemiplegia. What sort of hemiplegia? Internal capsule? Dense hemiplegia. What do you mean by dense hemiplegia? Upper limb and lower limb are equally involved. Which side will be the hemiplegia? Same side or opposite side?
Opposite side.
Yeah, so contralateral dense hemiplegia is the first and most important feature of internal capsule lesion. Clear? The second feature, as we said, the cranial nerve which is involved in all types of stroke. What is that? Seventh nerve. So seventh nerve palsy will happen. What type of seventh nerve palsy? Upper motor neuron type. What do you mean by upper motor neuron type? Upper part of the face is paired. Which side will be this paralysis? Contralateral, because the cranial nerve nucleus of the seventh gets opposite side supply. So contralateral seventh nerve palsy. That is the two important features that are there and which you will find in almost all stroke patients. The other features, remember the internal capsule has various limbs, isn't it? What are the limbs of the internal capsule? You have the anterior limb, genu, and posterior limb that is there. So we said the pyramidal tract is going somewhere here. What is located in the anterior limb and the posterior limb? Rest of it. What are the other structures that are there in the anterior limb and posterior limb? Yes, what are the other structures? What is there in the anterior limb and posterior limb of internal capsule? You have sensory fibers.
Corticospinal tracts.
Corticospinal is in the genu and posterior limb only. You have sensory tracts. Remember from the thalamus.
Corticopontine fibers.
Corticopontine fibers are also in the genu only. Okay. There are sensory tracts which go from the thalamus to various parts of the cortex. So you could have a thalamo-frontal, you could have a thalamo-parietal. So a lot of radiations that are going there which carry sensory problems. So whenever the sensory gets involved, you get something called as hemisensory loss. Which side will be the hemisensory loss? Contralateral. So this is a third feature that you can get in internal capsulation: contralateral dense hemiplegia, contralateral seventh cranial nerve involvement, contralateral hemisensory loss. And sometimes when you have a big lesion there, you have certain fibers that are running on either side of the internal capsule. Okay, it's running from front to back. What are those fibers? Any fibers which are running from the front and going on to the occiput? Anyone?
Association fibers.
Okay, somebody has written in the chart, it is the optic radiations. Okay, optic radiation. So when the optic radiation gets involved, what is the deficit that is called as?
Homonymous hemianopia.
Homonymous hemianopia. So homonymous hemianopia. So what do you mean by homonymous hemianopia? What does the word homonymous hemianopia mean?
Visual loss on the same side.
Same.
Like one nasal, one side it's nasal.
One side it's nasal, other side it is temporal.
Temporal.
So these are the four characteristic features of an internal capsule lesion. So please remember, if you find these features in a patient, it is suggestive of an internal capsule lesion. Now, do you find it in all patients with internal capsule lesion? Do you find it this? You would have seen a lot of stroke patients in your wards, but do you find these findings in all patients?
No,
You
sir.
generally do not find. Okay, you generally find the dense hemiplegia and maybe sometimes you find the sensory problem because the fibers are at different parts of the internal capsule. Different parts of the internal capsule, and each part is supplied by different blood vessel. Can any one of you tell me the blood supply of the internal capsule in brief? Anterior limb, posterior limb, genu.
Anterior is by recurrent artery of Habenua. Genu and posterior.
Which part of anterior is supplied?
Anterior and genu by recurrent artery of Habenua. And genu
Remember,
and
the anterior limb, the posterior limb and genu is divided into upper part and lower part. Okay, upper part and lower part. You understand? So if we say this is the internal capsule, I'll divide it into anterior, genu and posterior limb, the upper part and the lower part. So upper part is supplied by what? The main blood supply. Which is the main blood supply of the internal capsule?
Middle cerebral.
What is that? Which branch?
Charcot's artery.
Lenticulostriate branch of the middle cerebral artery supplies this part. Okay. As you said, the lower part of the anterior limb is supplied by, yes, what you said that time?
Hubner's artery.
Hubner's artery, that's there. The genu, the lower part of the genu is supplied by?
Charcot's.
Okay, Charcot's artery or direct branches of the ICA. Whereas the posterior limb totally supplied by either the PCOM or the direct branches of ICA. So there are different blood supply for different parts of the internal capsule. So since the fibers are located at different sites, so you do not get all these features. So supposedly I give you a patient of internal capsule lesion and he has all the features of internal capsule lesion. what is your inference? Here's all these 4 features are there. So what does it mean to you? It definitely means internal capsule, but what else does it mean to you?
Block at carotid level.
Internal carotid
Block
artery.
at carotid level. Agreed.
Internal
Okay.
carotid
But
artery.
that will not only supply the internal capsule, no, that will supply the entire thing. You will have entire cortex going. I'm talking about internal capsule lesion only, but all these features are there. So what does it mean to you? I've told you the fibers are at different part. Here there are some fibers, here there are. So what can involve all the fibers? What type of lesion can involve all the fibers? All the vessels cannot get blocked, na? All these 5 vessels which we told cannot get blocked all of a sudden, na? So what sort of lesion can
A
cause
tumor compressing the internal
tumor
capsule.
compressing? Okay, tumor is right, but we are talking about stroke. Tumor is absolutely correct. Whoever said it,
Hemorrhage.
hemorrhage. So please remember hemorrhage. So supposedly if one of the vessel bleeds there, what will happen? The blood will come out, and the blood coming out will start compressing the entire internal capsule. So please remember, whenever in a stroke patient you find all these features of internal capsule, your diagnosis becomes hemorrhagic stroke. Okay, did you get that point? Is that clear? So internal capsule is the commonest structure involved. Internal capsule has multiple blood vessels, all are end arteries, and each getting blocked can produce various manifestations. But the characteristic manifestations are these 4: contralateral dense hemiplegia, contralateral UMN 7th cranial lobe palsy, contralateral hemisensory loss, and homonymous hemianopia. But all of them are not usually seen because different structures are there. If you find it in a patient, then we are dealing either with a space occupying lesion or a hemorrhagic stroke. Okay, so that's about the internal capsule, by far the most common site of stroke. The second important site of stroke we are talking about is cortex. Now, cortex as a site of stroke. So if you say this is the motor homunculus I'm drawing here, are you able to see that? Okay, so you have the, how are the fibers arranged? How are the, which fibers are located medially, which are located laterally? Can anyone tell you?
Leg fibers medially and upper fibers laterally.
Correct. So leg is somewhere here located, the face, the trunk, and the hands will be located laterally, correct? So that's the arrangement that is there in the motor homunculus. Why do you have to know is because the blood supply is also something like that. So the blood supply that we have, if you see this as the blood supply here, the medial part is supplied by which vessel?
Anterior
Anterior
cerebral.
cerebral artery. Whereas the lateral part is supplied by the middle cerebral artery. So you have to remember this. The medial part is supplied by anterior cerebral, whereas the lateral part is supplied by middle cerebral artery. So supposedly I say anterior cerebral artery gets thrombosed or blocked. So which part of the body gets involved most?
Leg.
Leg is getting involved. So which side leg? Opposite side leg, isn't it? So you get monoplegia of the leg, or sometimes you can get hemiplegia, but that hemiplegia will have lower limb more than upper limb involvement. What do you call this hemiplegia as?
Differential hemiplegia.
I told the name for this beginning. Crural hemiplegia. So low limb getting involved more than the upper limb. Supposedly the middle cerebral artery gets involved, you get involvement of the hands as well as the face. Hands and the face together gets involved. So you get upper limb predominant hemiplegia or the brachial hemiplegia. So what is very important for us to know is in the cortical lesion, the upper limb, sorry, nothing happened. Where did it go? So in a cortical lesion, you have to understand that the upper limb and lower limb are never equally involved. It's always either crural dominant or it is a brachial dominant that you get. So it is never dense. That is what we have to understand in case of a cortical lesion. The next features of a cortical lesion that you have to understand, in a cortex, whenever the cortex gets involved, what are the other features which will tell us that this is a cortex that is getting involved? What are the other functions of the cortex that can get affected?
Speech.
Speech, very important. So speech can get affected if you have a dominant cortical involvement. So as we have discussed, in the dominant cortex. Which is the dominant cortex? In almost majority of the population, the dominant cortex is the left cortex, isn't it? So left-sided. So if you have a left-sided cortical involvement, you can get aphasia. So that's the second feature that you could have, aphasia. Yes. What else could be there in the cortical involvement?
Apraxia.
Apraxia. What do you mean by apraxia?
Skilled movement. The person cannot do the skilled movements.
Okay, inability to perform the skilled motor activity. Again, remember, this is a function of the non-dominant cortex. So aphasia is dominant cortex, apraxia is non-dominant cortex. Will the facial nerve get involved? Will you have facial nerve involvement?
In dominant part,
Yes.
it will come.
Yes, facial nerve can get involved. So you can get a UMN, seventh nerve palsy, on the opposite side. Okay, and a very important thing that you have to remember always on history, if a patient gets seizures, okay, patient gets seizures. So if there is a seizure on history, it always says the patient has a cortical involvement, because seizure is nothing but irritation of the cortex. There is an irritation of the cortex. So if there is a seizure, that means there is a cortical involvement. So history wise and examination wise, you say this lesion is in the cortex. If you have a non-dense hemiplegia, if you have an aphasia in a patient who has right-sided hemiplegia, or else if there is a left-sided hemiplegia, sometimes the patient can have apraxias and the patient has seizure on history. And again, remember, when the non-dominant parietal lobe gets involved, sometimes non-dominant, okay, LOC is not a feature. LOC, it is not, I think somebody in the chat has asked about loss of consciousness. Again, loss of consciousness is not specific for the cortex. Loss of consciousness can occur in brainstem lesions. Loss of consciousness occurs in raised intracranial tension also. So it's not specific for the cortical involvement. Okay. The other important, as somebody has already answered it in the chat, if the non-dominant parietal lobe gets involved, you get a symptom called as hemi-neglect. Okay, please remember this. The patient refuses to see the side. So non-dominant parietal, I told you. So the right-sided is a lesion. So the patient has a left-sided hemiplegia, and the patient refuses to see that left side. So his head is always turned to the right. So it's a very, very specific lesion of a non-dominant parietal lobe lesion. So these are the features that you'll have in a cortical stroke. In a cortical stroke, there are other functions can be abnormal, but please remember aphasia, apraxia, non-dense hemiplegia, and seizures. If you have in a patient, you have a cortical lesion. Now, do we get aphasia in an internal capsule lesion? A very important question they ask you. Patient has all the features. You have a patient who has dense hemiplegia and has aphasia also. So what do you think? Patient has aphasia and there is dense hemiplegia. So what is the problem you think?
Middle cerebral artery.
Okay, the entire middle cerebral artery, but then the patient will have other features also if the MCA gets involved. So please remember, internal capsule can also cause something like a motor aphasia. Okay, though it's not common. If there is a dense hemiplegia and the other cortical functions are normal, then per se in the internal capsule lesion can produce something like a motor aphasia. But for all practical purposes, please remember aphasia means dominant cortex. So it could be a Broca's aphasia, it could be a Wernicke's aphasia. Please remember your middle cerebral artery finally comes and gives out two branches. You have a superior division and an inferior division. The superior division goes and supplies the Broca's area. The inferior division goes and supplies the Wernicke's area. So if the superior division of the middle cerebral artery gets involved, you get Broca's aphasia. If you have the inferior division of the middle cerebral artery gets involved, you get Wernicke's aphasia. Supposedly you have a stem of the middle cerebral artery getting involved, you get something called as a global aphasia. So you have the various other syndromes of middle cerebral artery. They call it as M1 syndrome, M2 syndrome. I think we'll discuss that maybe in a further class. It's not very important. For undergraduate level, please remember internal capsule, cortex. What are the 1, 2, 3, 4, 5 features? Now the next site which I told you is subcortex. Again, it's not a very common site. You get subcortical involvements generally whenever there is something called as watershed region. The subcortical region is something called as a watershed, where the blood supply is not individual. It depends upon the other sites for the blood supply. So whenever we have a hypotension or you have a multi-infarct state, such lesions would occur. Why do you get seizure in stroke? When there is an infarct, it is a dead area. It causes as an irritative focus. So it produces seizure. That's the cause of seizure. So cortex is the site where if you have an infarct, it produces a seizure because it's a dead area. That's how you get seizures. I was speaking about something else. I was speaking about subcortex. So subcortex, remember, they will neither have features of cortex, they will neither have features of internal capsulation. So they may have some sort of a monoplegias, but then they may the speech etc. may be normal. So those are the lesions where you get subcortical lesions. So more of in the imaging, you do an MRI and you find subcortical infarcts. Clinically, it will not little be difficult to make out that. So these are the anterior circulation strokes. So if you get a question on anterior circulation strokes, please remember we are talking about the middle cerebral artery, the anterior cerebral artery, and the carotid. So the sites are internal capsule, cortex, and subcortex. Now, one question they ask you, supposedly the internal carotid itself gets involved, what will be the features? If the internal carotid gets blocked, what other features the patient will have other than hemiplegia, hemisensory loss, and global aphasia? What else feature will a patient will have if the internal carotid artery is directly getting blocked?
Amaurosis fugax.
Yes, very important. This is one sign before the MCA etc. is given. The last branch that it gives is the ophthalmic artery. So if the internal carotid artery gets involved, you get monoocular blindness. Amaurosis fugax is a transient one. It's a transient one. It's a TIA. But if you have blindness, monoocular blindness, then that would indicate an internal carotid artery getting involved. So ICA stroke will have, along with the MCA and ACA features, it will also have a patient will have monoocular blindness. Okay, so that is the anterior circulation strokes. We'll go on to the posterior circulation stroke, but before going to that, as we discussed in the anterior cerebral artery. Now, can you get paraplegia in a patient with stroke? We are talking about hemiplegias in stroke. Can you get paraplegias, both lower limbs involved? Can you get that in stroke? Okay, so this anterior cerebral artery which we discussed, this is the anterior cerebral artery we were talking about. It supplies the leg area. So there is one more anterior cerebral artery on this side which supplies the leg area there. Now, in a good amount of population, you have an abnormality called as an unpaired anterior cerebral artery. What do you mean by unpaired anterior cerebral artery? Unpaired anterior cerebral artery means there is only one anterior cerebral artery. The other side area is going to be supplied by the anterior communicating artery. So you have an anterior cerebral artery here, and through the anterior communicating, the other side cortex is getting supplied. So supposedly this unpaired anterior cerebral gets thrombosed. What will happen? This will also get infarcted, and the opposite side also gets infarcted. So the lower limb on this side and the lower limb on this side also can get involved. So you can get paraplegia in case of unpaired ACA thrombosis. Please remember this. It's a common anatomical variant. It's not a rare condition. Unpaired ACA causes paraplegia. If you have a paired ACA, one side getting involved produces opposite side lower limb involvement. Am I clear with that? Unpaired ACA can produce paraplegia. We're talking about stroke. Some other fellows have written of the other causes, like they have written about CVT as well as hydrocephalus. They are not part of stroke, but they are part of other conditions where it can compress on both of the frontal lobes there, and it can produce a bilateral weakness sort of features they can have. Paraplegia can be produced due to that. Okay. So coming on to the posterior circulation stroke. By posterior circulation stroke, we are meaning the vertebrobasilar circulation that is happening there. So we are talking about the sites of posterior circulation stroke. The first site we are going to look at is the midbrain. So what happens in the midbrain? So if I take, okay, you have the midbrain there. So the cranial nerves that are located in the midbrain, the two important cranial nerves that are located, the third and the fourth cranial nerves are located in the midbrain. So third and fourth cranial nerve nucleus is located there on both sides. So the pyramidal tract comes like this and goes down. And so what are the features they'll have in a midbrain stroke? That's what is important for us to make out. So in a midbrain stroke, if there is a lesion on the right side here, patient will have hemiplegia. Which side hemiplegia? Opposite side hemiplegia. So contralateral hemiplegia will be there. So contralateral hemiplegia, that's the first feature they'll have. The second is the third nerve nucleus is getting involved there. So what will they have? They will have ipsilateral ophthalmoplegia. Ipsilateral ophthalmoplegia. Please remember, third nerve is involved on this side, hemiplegia is on the opposite side there, but the ophthalmoplegia is on the same side. So ipsilateral ophthalmoplegia, contralateral hemiplegia. This is the classical syndrome. Anybody can tell me what's the name of this syndrome?
Weber's.
Yes, this is called as the Weber syndrome. The most common syndrome that you have in a midbrain stroke, ipsilateral ophthalmoplegia, contralateral hemiplegia. That's a common syndrome that you have. Also, for there are many other syndromes that are located. Remember, there are other structures that are there in the midbrain. What are the other important structures that are located in the midbrain? Anybody can tell me?
Red nucleus is present.
So you can have a red nucleus that is present there. So red nucleus can get involved. So if the red nucleus gets involved, what is the symptom the patient can get?
Tremors.
Tremors, very important. And that's a coarse tremors the patient can develop, correct? So the patient can have coarse tremors due to red nucleus involvement, correct? Any other structure? Any other structure?
Ataxia will be there.
Ataxia, correct? Why do they get ataxia? Why do they get ataxia? Can somebody tell me? Who told ataxia?
Cerebropontine rubral fibers are there.
Cerebropontine rubral, that's a big word. Okay, remember the brain stem, the three parts of the brain stem, midbrain, pons, and medulla. How are they connected to the cerebellum? How are they connected to the cerebellum?
Peduncles.
Peduncles. How many peduncles are there?
3.
3, isn't it? Superior,
middle,
middle, and inferior. Superior connects the midbrain to the cerebellum. Middle connects the pons to the cerebellum, and the inferior connects the medulla to the cerebellum. So all the blood supply to these peduncles are going through the cerebellum are going through the peduncles. So the peduncles get involved, and there are tracts in the peduncles, so they can get tremors. Correct. That's a very important feature. So the patient can have tremors. Any other important structure? Something black that's located. Black.
Substantia nigra.
Substantia nigra, isn't it? So substantia nigra is located there. So if that gets involved, what will the patient have?
Rigidity.
Yeah, what is the disease? What is the disease?
Parkinson.
Parkinson's. What sort of Parkinson's? Both sides or one side only?
Unilateral.
Unilateral Parkinson's, or what we call it as a hemi-Parkinson's. So remember, midbrain involvement produces two important features. One is ipsilateral ophthalmoplegia, contralateral hemiplegia. So that is the classical syndrome of Weber's. Then you have the other syndromes. You have various named syndromes are there. You have the Claude syndrome, where you have opposite side ataxia, third nerve involvement. You have a North-Nagel syndrome. And you have, as you said, the red nucleus involvement producing coarse tremors, hemi-Parkinson's, because the substantia nigra is getting involved. So you can have all these syndromes. Also, if you remember in your anatomy, there are other nucleus that are located related to the oculomotor, which are there in the midbrain. You have something called as a tegmentum and the tectum. You heard of it? So in the tectum, you have various nucleus like the pretectal nucleus, the Edinger-Westphal nucleus. These are involved with the light reflex, the accommodation reflex is involved.
Consensual reflexes.
Yes. So these also can get involved. Okay. In ophthalmology, you would have learned a syndrome called as Parinode syndrome, isn't it? Parinode syndrome is a very important syndrome which is involved in the midbrain. So they have predominantly problems with the eye, especially the 346 nerves. That is not 346, the 3 and 4th nerve, especially the light reflex and accommodation reflex. So they have upgaze palsy, pupillary dilatation, and they get a very classical nystagmus called as the convergence retraction nystagmus, or otherwise called as the Collier's sign. So I think in ophthalmology you would have learnt about the Parinode syndrome. So midbrain lesions, just remember, for simple reasons, remember if the third nerve is involved on one side, hemiplegia is on the opposite side, you're dealing with midbrain. Okay. Coming on to the next site that we have is the pons. So pons. So what are the structures that are located in the pons? So you have the pons here, right and left pons. So pyramidal tract is going. So if you have a lesion here, you get contralateral hemiplegia, isn't it? So contralateral hemiplegia will be there. The cranial nerves that are located in the pons. What are the cranial nerves that are located in the pons?
Sixth,
Sixth
seventh.
cranium.
6, 7,
Sixth
8.
and seventh cranial
Seven.
nerve. So sixth and seventh cranial nerve predominantly that are located there. So you get paralysis of these two nerves. So you get facial nerve palsy now. So seventh nerve palsy is coming, and seventh nerve palsy is now. Which side will be the seventh nerve palsy? Which side will be the seventh nerve palsy? Ipsilateral, isn't it? It will be ipsilateral seventh nerve palsy that you're going to get, because the seventh nerve nucleus is getting involved there. So ipsilateral seventh nerve palsy, ipsilateral abducens nerve palsy, that is the lateral rectus will be paralyzed, whereas the patient will have hemiplegia on the opposite side. So whenever you have a lesion in the pons, you have contralateral hemiplegia, ipsilateral seventh nerve palsy. What type of seventh nerve palsy now? It's a nucleus getting involved. So what type of palsy will it be? UMN or LMN? Will it be upper motor or a low motor? LMN type of facial palsy. So how do you identify LMN facial palsy? How do you identify?
Same side,
Same
upper
side?
and lower face.
Upper and lower both are getting involved. So you have contralateral hemiplegia, ipsilateral LMN type of seventh nerve palsy that is there. So the entire face is getting involved, isn't it? So this classical syndrome is called as?
Millard-Gubler.
Yeah, it's called as a Millard-Gubler syndrome. So that's the commonest syndrome that you get in case of a pontine stroke. You get Millard-Gubler syndrome, where you have hemiplegia on the opposite side and seventh nerve involved, plus or minus abducens nerve involved on the opposite side of that. So this is the Millard-Gubler syndrome. Again, you can have only abducens involvement, because remember, the sixth nerve is located centrally medially, whereas seventh nerve nucleus is located laterally there. So with the hemiplegia, usually sixth can get involved. Okay, the seventh may not get involved. So you have other syndromes also of the pons, but important for us to know is the Millard-Gubler syndrome. That's the commonest syndrome that we have. Okay, coming on to the next location, that's a very important location for us, is the medulla. Okay, so we are talking about the medulla now. So when we discuss the medulla, what is important for us to know about the medulla is, we discussed about the rule of 5 that time, rule of 4. There are two other rules of 4 that are there in the medulla. There are two more rules of 4. So we have 4 structures in the medulla which are located in the center, 4 structures which are located in the center, and there are 4 structures which are located in the side. So that's the next rule that we have in the medulla that we have to understand. Now in medulla, what are these 4 structures which are located in the center? So center, we can call it as midline. So all of them start with M. So central midline structures are starting with M. So what are these M structures which are located in the center of the medulla? So the first one we have is the motor pathway or the corticospinal tract. Motor pathway or the corticospinal tract which we are discussing. So the motor pathway. The second M is the motor cranial nerve, which is the cranial nerve that's located in the medulla, and it's located medially. Which cranial nerve? 12th cranial nerve. So 12th cranial nerve. Okay. The next medial pathway, midline structure which starts with the middle, is the medial longitudinal vesicle. And the fourth M is the medial lemniscus. So I'm just repeating, in the medulla, in the center or the midline, you have 4 structures which start with M. What are they? Motor pathway, motor cranial nerve 12, medial longitudinal vesicle, and medial lemniscus. So you have a syndrome in the medulla which involves the medial part of the medulla, We call it as the medial medullary syndrome. Okay, medial medullary syndrome is a syndrome of the medulla which involves the medial part of the medulla. That's so in that medial medullary syndrome, you have involvement of these four structures. So if the motor pathway gets involved, what is the feature they'll have? If the motor pathway is getting involved, what feature they'll have? They will have hemiplegia. So which side will the hemiplegia be? Which side will the hemiplegia be?
Contralateral weakness.
Okay. Again, remember, medulla is the site where the decussation is happening, isn't it? So this is the medulla. If you say the decussation of fibers, the fibers start from this side, come and decussate onto the opposite side. So if you have lesion above the decussation, hemiplegia will be contralateral. If you have a below the decussation, you will have ipsilateral. So this is the site where your crossed and uncrossed comes. Till now, all the hemiplegias were crossed. In the medulla, above the decussation, you have contralateral hemiplegia. Below the decussation, you have ipsilateral hemiplegia. That is what you have to understand. So hemiplegia can be contralateral or ipsilateral based on the site of decussation. The second feature they'll have is because of the involvement of the cranial nerve 12. So cranial nerve 12 paralysis will be happening in the medial medullary syndrome. So there will be paralysis of the tongue. The tongue will be wasted and it will be deviated. Okay, so tongue wasting and deviation will occur towards the side. So that is the second feature they'll have, 12th nerve involvement. Next is they'll have involvement of this medial longitudinal fascicle. Now, what is medial longitudinal fascicle? Anyone can tell me what is medial longitudinal fascicle?
Fasciculus gracilis and fasciculus cuneatus.
No, that is not medial longitudinal fascicle. Medial longitudinal fascicle.
Horizontal
MLF.
gaze. Horizontal gaze.
Conjugate gaze.
Correct. So you have the gaze, the horizontal gaze. Horizontal gaze means when you're looking onto the right side, one eye, lateral rectus should act, other side, medial rectus should act. What is the nerve supplying the medial rectus? Which nerve supplies the medial rectus?
3,
Third nerve.
Third nerve. Which nerve supplies the lateral rectus?
6,
6.
Sixth nerve. Where is the sixth nerve nucleus located?
pons,
Pons. Where is the third nerve nucleus located?
Midbrain.
Midbrain. So these two cranial nerve nucleuses are located at two different sites, and one side third nerve should get stimulated, opposite side sixth nerve should get stimulated. So to facilitate this, there is a group of interneurons. There is a group of interneurons which connect these two cranial nerves. That is, the sixth cranial nerve on one side is connected to the third cranial nerve on the opposite side, and that group of interneurons is called as medial longitudinal fascicle. Now, when you have a medial longitudinal fascicle involvement, the deficit that you get is called as INO. Have you heard of this INO?
internuclear ophthalmoplegia.
Yeah, it is called as internuclear ophthalmoplegia. Now, how do you make out this internuclear ophthalmoplegia? What features the patient will have?
Same side there is adduction palsy,
Hmm.
and contralaterally the gaze is bad.
Gaze is impaired, or what else will happen in the other eye?
Nystagmus is seen, sir.
Okay, so there will be problem with adduction on one side, opposite eye there will be nystagmus. So that is what you have to understand. So otherwise, for all practical purposes, please remember MLF involvement produces internuclear ophthalmoplegia, loss of adduction on the same side, nystagmus on the abducting eye. So that is what you get. Very important, MLF is one group of interneurons. It is starting from the medulla. It is there right up to the midbrain. So it is located in the center of the midbrain. There is in the center of the midbrain, it is there right in the center of the midbrain, that is there. So because of that, you can get this involvement of the internuclear ophthalmoplegia. And one disease where this MLF is classically involved, one disease,
Sclerosis.
multiple sclerosis. Very good. So multiple sclerosis is a disease where MLF classically gets involved. And though in India, we do not have so many cases of multiple sclerosis, in the West, multiple sclerosis is a very common disease and they get a lot of internuclear ophthalmoplegia. But please remember, where is the internuclear ophthalmoplegia site of lesion? Is in the medial longitudinal fascicle. Where is the medial longitudinal fascicle located? It is located in the medial part of the brainstem. Okay. Okay. The fourth feature that they have is due to this medial lemniscus. What is this medial lemniscus? What is this medial lemniscus?
Cuneatus and gracilis fibers.
Correct, correct. So it is the continuation of the fasciculus, cuneatus and gracilis. So what do they carry?
Dorsal column sensory fibers.
What
Touch
is the
and
dorsal?
fine touch and proprioception.
Okay, so joint position, proprioception, vibration, fine touch is carried through this pathway, and that is going to the thalamus from this. So what will happen if the medial lemniscus get involved? What will be the problem that the patient will have?
Contralateral
force.
reduction in
Yes,
proprioception.
contralateral loss of proprioception. Please remember it is contralateral loss of proprioception because it is decussated in the lower part of the brainstem and come up. What will the patient will be able to appreciate pain and temperature? Will the patient be able to appreciate pain and temperature?
Yes.
Yes, because that is going to go from the separate, isn't it? Spinal limb. It's on the lateral side.
Spinal
So,
thalamic.
yeah, it is in the spinothalamic. It's on the lateral side of the brainstem. So, whenever you have a medial medullary syndrome, you will have these 4 M's that is getting involved. So, what are the 4 M's? Motor pathway. So, the patient will have hemiplegia. Motor cranial nerve 12. So, the patient will have tongue weakness. MLF, medial longitudinal fascicle. So, the deficit is internuclear ophthalmoplegia. 4th M is medial lemniscus. Involvement produces loss of posterior column sensation in this patient. So, medial medullary syndrome, the other name for the medial medullary syndrome is called as a Jerine syndrome. Okay, Jerine is D-J-E-R-R-I-N-E, D is silent there. So, that is the medial medullary syndrome. Now, coming on to the fourth rule of 4 that we had, the fourth rule of 4 that we had. What are the 3 rules of 4 we have finished so far? Anyone can tell me what are the 3 rules of 4 we have finished?
Division of the 4 based on the
Okay, so
4
4
number in the
cranial
cranial
nerves.
nerve.
Okay, correct.
Then
That's the first one. Second one was
midline there will be 4
midline.
motor
There are
neurons.
4 cranial nucleus. Correct. The third one was
And lateral there will be 4 nucleus. That is.
Third one was just now what we discussed.
Just motor pathway
4
and
midline
then
structures which are starting with M. Okay, coming on to the fourth rule, that is we have the 4 structures which are located in the side of the medulla, side, which start with S. So we are discussing the most important posterior circulation syndrome that we have is the lateral medullary syndrome. Please remember, lateral medullary syndrome is the most important syndrome in the posterior circulation. That's the commonest syndrome that you get in the posterior circulation. That's the commonest syndrome you get in the posterior circulation. So there are 4 structures that are located in the side which start with S. Okay, I think somebody in the chat has already mentioned. The first structure that we have is what we call it as the spinothalamic tract. So spinothalamic tract. If I zoom, will the handwriting be better or will it be less? Okay, spinothalamic tract, that's the first S. The second S is something called as a spinal tract of trigeminal nerve. That's the second S. The third S is something called as a sympathetic tract. And the fourth S is what we call it as the spinocerebellar tract. So please remember, we are talking about the side of the brainstem. We are talking about the lateral medullary syndrome, the most important lateral medullary syndrome. It has 4 S's because they are in the side. One is the spinothalamic tract, spinal tract of trigeminal nerve, sympathetic tract, and spinocerebellar tract. Now, what is spinothalamic tract? What is spinothalamic tract?
From spinal cord to thalamus.
Correct. What does it carry?
Pain and temperature.
Temperature.
Correct. Pain and temperature. Pain and temperature from the body. Which side of the body? If I'm talking about the right side of the medulla, which side body spinothalamic tract is there?
Opposite side. It crosses at
side.
the spine.
Yeah,
It causes
because
at the
the pain and
spinal.
temperature, very importantly, crosses in the spinal cord itself, isn't it? It crosses in the spinal cord and ascends up. So spinothalamic tract is the tract which is carrying pain and temperature from the opposite side of the body. Correct. The next tract we are talking about is spinal tract of the trigeminal nerve. Now, trigeminal nerve, where is it located? Trigeminal nerve?
Pons.
It is located in the pons there, but then you have a spinal tract of the trigeminal nerve, which comes from the spinal cord and goes up, okay, which carries the pain and temperature sensation of the face. So that is in the lateral part of the medulla. Next is the sympathetic tract, which is required for your pupils and the pupillary dilatation or pupillary constriction that is required is sympathetic tract that is there, as well as it is required for the sweating of the face. And then you have the spinocerebellar tract. So these are the 4 S's that are there in the site. Now, if these get involved, what will be the features? Okay, so supposedly you have the spinothalamic tract that is getting involved. What will happen?
Contralateral loss of pain.
Yeah,
and temperature.
contralateral loss of pain and temperature. Where?
So the
Trunks
body.
and limbs.
Body, isn't it? So body, contralateral loss of pain and temperature. Okay. Spinal tract of 5th nerve. What will be the problem? There will be loss of pain and
Ipsilateral loss of
temperature.
pain and temperature.
Correct. Ipsilateral loss of pain and temperature in the face. Ipsilateral face. So please remember, when we discussed about internal capsule, what is the sensory problem I told you? Internal capsule will have hemisensory loss. That means opposite side face and body complete sensation loss. Hemisensory loss, meaning opposite side face and body to the site of lesion, opposite side. If supposedly right-sided internal capsule, left-sided body as well as the face. That is called as hemisensory loss. But what do you get in lateral medullary? You get crossed sensory loss. Please remember this word, crossed sensory loss. Crossed sensory. Cross sensory meaning same side face, opposite side body. So whichever side the facial sensation is lost, that is the side where is the site of lesion for. So right-sided lateral medullary, right-sided facial sensation loss, opposite side, left-sided body sensation is lost. So that is what we get cross sensory. Okay, and only pain and temperature is lost. The posterior column sensation is preserved. Correct? Why is the posterior column sensation preserved?
Dorsal column.
Because that is going through the medial part of the medulla. So pain temperature lost, dorsal column sensation is preserved. What do you call this deficit as?
Dissociative sensory loss.
Dissociative sensory loss. Very good. So crossed dissociative sensory loss you get in case of lateral medullary syndrome. And when the sympathetic tract gets involved, what is the problem you get?
Horner syndrome.
Horner syndrome.
Very good. Yes. So Horner syndrome, what are the features? Can one of you tell me what are
Mild
the features?
ptosis.
Anhydrosis.
Anhydrosis.
Meiosis.
Correct. Ptosis, meiosis,
Enophthalmos.
enophthalmos, and
Loss of ciliopupillary reflex.
correct. Loss of ciliospinal reflex. Somebody wants me to repeat something. What is the thing you wanted to repeat? I could not catch that. Okay. So Horner syndrome. So the patient will have meiosis, anhydrosis, loss of ciliospinal reflex, mild enophthalmos will be there. And spinocerebellar tract, when the spinocerebellar tract gets involved, what will they have? Spinocerebellar tract getting involved?
Ataxia.
Ataxia, correct. So spinocerebellar tract getting involved, they have ataxia. So a patient with lateral medullary syndrome will have crossed sensory loss. Same side face, opposite side body. Patient will have Horner syndrome on that side. Patient will have ataxia on that side. Ataxia is because of the spinocerebellar tract getting involved. What is this dissociative? I think somebody wants me to explain what is dissociative sensory. Dissociative sensory means one sensation is lost, the other sensation is preserved. So remember, you have 2 tracts. You have the spinothalamic and you have the posterior column sensation. So posterior column sensation is joint position, proprioception, fine touch. Whereas the spinothalamic is pain and temperature. So in some conditions, you have pain and temperature is lost, and the other sensation is preserved. Like in lateral medullary syndrome, you have only pain and temperature is lost because spinothalamic is gone. Whereas in medial medullary syndrome, you have the other one which is lost. So this is what we call it as dissociative sensory loss. But please remember, the word dissociative sensory loss is classically described for which disease? Which disease? Which disease produces dissociative sensory loss? Syringomyelia. Please remember, syringomyelia. Have you heard of syringomyelia? There is a cavity inside the spinal cord which dilates. So right in front of the cavity, the pain and temperature fibers are crossing. So in syringomyelia, you get classical dissociative sensory loss, but you can get dissociative sensory loss even in case of lateral medullary syndrome or medial medullary syndrome also. Which side will be the Horner? Same side Horners. Okay, same side will be the Horner. What are the other features this patient will have? Lateral part of the medulla, what else is located? We discussed that time. What else is located in the lateral part of the medulla? Cranial nerves, isn't it? What are the cranial nerves which are located in the lateral part? 9th, 10th, 11th cranial nerves are located. 8th is little up there. So 9th, 10th, 11th cranial nerve is located. So whenever we have 9th, 10th, 11th cranial nerve involvement, the patient will have hoarseness of voice. They'll have nasal regurgitation. They'll have loss of gag reflex. When you check the gag reflex, that will be lost. So 9th, 10th, 11th cranial nerve also will be involved. And a very important feature in history you have to remember is a very important symptom. Whenever this symptom is there, you should always suspect lateral medullary. Anybody can tell me what is that symptom?
Hiccups, persistent hiccups.
Very important, persistent hiccups. Remember, in the lateral part of the medulla, there is a nucleus. Okay, you have a nucleus. One is for the vagus and one is for the facial nerve. One is the NTS and the other one is nucleus ambiguous. So these can get involved, and because of that, the patient can have persistent hiccups. So whenever a patient with stroke complains of hiccups, you should always check for a lateral medullary syndrome. Now, very important syndrome. Why this lateral medullary syndrome is so important for us? Because that's the most common site of posterior circulation stroke. Again, like internal capsule had 5 blood supplies, the lateral part of the medulla also has 5 or 4 blood supplies. Most important one is the vertebral artery. Then you have something called as the pica. Pica stands for posterior inferior cerebellar artery. Then you have the superior, middle and inferior cerebellar artery. So all these supply the lateral medullary. Very common MCQ, they ask you what is the commonest artery that is blocked in lateral medullary syndrome?
Vertebral.
Okay. Please remember, this is a question which is debatable because 2-3 years back, the artery which was always considered as getting blocked was the pica. Maybe 2 or 3 editions prior, if you see the books, always they used to say pica is the cause for the lateral medullary syndrome. But presently, if your MCQ is asked, answer is vertebral artery. So vertebral artery blocking produces lateral medullary syndrome. Okay, so that is what you have to remember. The other name for lateral medullary syndrome, or more often it is called as
Wallenberg syndrome.
Wallenberg syndrome. So please remember again, you can get a short notes, clinical features of Wallenberg syndrome. You're going to write this 3S, 4S's. Then you're going to write that there is also 9th, 10th cranial nerve involvement. Now, what is so special about this stroke compared to all other strokes? What is so special about stroke due to lateral medullary syndrome? What is so special? Or what is the difference from the other strokes that we have in contrast to your lateral medullary syndrome?
Horner syndrome.
Yes, Horner syndrome. Yes, Horner syndrome, you can have other cause also. But yes, Horner syndrome is specific. Whenever we say stroke, what is the first and most important thing that we always speak about when your patient has stroke? So what are you going to go and check in the patient?
Hemiplegia.
Hemiplegia, correct. You're going to check for motor weakness. You're going to check for reflexes, exaggerated reflexes. You're going to check for Babinski sign, correct? So will this be there in a patient with lateral medullary syndrome?
No, sir.
Yes, that's a very important thing that you have to remember. In case of lateral medullary syndrome, this is a stroke where your corticospinal tract is not getting involved. So corticospinal tract will not be involved. Very common in the exam, they say, this patient has left lateral medullary syndrome. Which plantar will be extensor? Which plantar will be extensor?
None.
Babinski.
Patient has left lateral medullary syndrome. Which plantar will be extensor, right or left?
So both will be flexor.
Neither. Okay. So there is no corticospinal tract involvement. So you do not have a plantar extensor. So this is a stroke where you do not have plantar getting extensor. That is what you have to understand. So lateral medullary syndrome is a common syndrome. In the posterior circulation, that's the most common stroke that you get, but you do not have motor weakness in these patients. So this will finish your brainstem syndromes. We told about the midbrain syndrome. We told about the pontine syndromes, and then we discussed about the lateral and the medial medullary syndromes. The last location of stroke is the spinal cord, isn't it? So spinal cord, you can get stroke. So as we discussed in spinal cord stroke, what should be the site where the spinal cord should get involved to produce stroke? It should be above the C4 level. It should be above the C4 level. You can get spinal cord involvement. So to produce hemiplegia, one side should be weak. What sort of lesion should be there in the spinal cord?
Hemitransaction.
Should have a hemisection of the cord. What do you call that syndrome as?
Brown-Sequard.
Brown-Sequard syndrome. Again, it's a very, very rare thing to happen because what's a common cause for Brown-Sequard syndrome? One side of the spinal cord should get cut.
Any bullet or stab injury?
Yeah, bullet or stab injury. It can't happen with stroke. Why you can't get it in stroke? Why can't you get a Brown-Sequard sort of picture in stroke? How is the blood supply of the spinal cord?
So anterior spinal artery.
Anterior spinal artery is there. There is posterior spinal artery is there. How do they supply? They supply half? One half?
No, 1/3 and 2/3.
They supply from front and back, isn't it? So if one gets blocked, you will have anterior 2/3 getting going. So the patient will have paraplegia or quadriplegia. So to get stroke due to a vessel getting blocked in the spinal cord is rare. So usually if you get a spinal hemiplegia, it's because either due to trauma or a gunshot injury. So they will have classical features of Brown-Sequard syndrome. So what are the features of Brown-Sequard syndrome?
Same side there will be hemiplegia.
Correct. Same side hemiplegia.
Contralateral loss of pain and temperature.
Contralateral loss of pain and temperature.
And ipsilateral loss of all the
posterior column sensation. So posterior column sensation will be lost on the same side. Hemiplegia will be on the same side, but the pain and temperature will be lost on the opposite side. So these are the localizations of hemiplegia that we discussed. So this is how you localize hemiplegia. So we discussed about the various sites of hemiplegia. We discussed that you have a anterior circulation, we have a posterior circulation that is there. So anterior circulation, the sites we have discussed was, what are the sites in the anterior circulation we discussed?
Lower limb.
No, anterior circulation, what are the three sites?
Internal capsule.
Internal capsule, cortex and subcortex. That is the three anterior circulation. The posterior circulation sites we discussed was midbrain, pons, medulla, and rarely the spinal cord. And we discussed how do we localize based on each. Most common site, internal capsule. What are the features? Contralateral dense hemiplegia, contralateral UMN facial palsy, contralateral hemisensory loss, and homonymous hemianopia. We say cortex if the patient has aphasia, apraxias, or seizures. And cortex never has dense hemiplegia. It is either upper limb predominant or lower limb predominant hemiplegia that could be there in a cortical lesion. Midbrain, third nerve on one side, hemiplegia on opposite side. The syndrome is named Weber syndrome. Pons, you have ipsilateral LMN facial palsy, contralateral hemiplegia, plus or minus sixth nerve involvement on the side, and that syndrome is called as Millard-Gubler syndrome. When we came to the medulla, we discussed that could be a medial medullary syndrome, there could be a lateral medullary syndrome. If there is a medial medullary syndrome, the 4 M's are getting involved. Motor pathway produces hemiplegia. Hemiplegia can be ipsilateral or contralateral because decussation. Second M is motor cranial nerve 12. So the 12th nerve weakness will happen. Third M is MLF, medial longitudinal fascicle deficitous internuclear ophthalmoplegia. And the fourth M that we have is medial lemniscus. So the patient will have loss of posterior column sensations. Coming on to the most important lateral medullary syndrome, 4 S's that we had: spinothalamic, spinal tract of trigeminal nerve, sympathetic, and spinocerebellar. So the patient has crossed sensory loss. Same side face, opposite side body. Horner syndrome, ipsilateral ataxia, hoarseness of voice, loss of gag reflex, and hiccups as a symptom that they could have. So that is lateral medullary syndrome. And the rarest of the strokes that you could have is the spinal hemiplegia, where you have the classical Brown-Séquard, same side motor and posterior column, opposite side sensory of pain and temperature lost. Now it is important for us to localize, because clinically we can order for a specific investigation. Remember, whenever we require the brainstem to be evaluated, MRI is always better. A CT scan will not pick. And brainstem strokes, since the cranial nerves get involved, the patients can have various complications. Since they will not be able to swallow, they can have problems with the aspirations, and aspiration pneumonias, etc. can happen with that. And also, ataxia is an important feature of posterior circulation, that is the brainstem getting involved. Whether the patient recovers or what is the recovery chances with stroke basically depends upon the amount of infarct that is there. It doesn't depend upon the site alone. It's the how big is the infarct. The infarct, a big infarct in a non-critical area may not produce any deficits. Small infarct in a critical area, the patient can succumb. So the recovery depends upon the sites that is involved, the size of the infarct, and the comorbids that the patient has. So I think that is what we discussed about localization of stroke. Importance of localization as a part of treatment. Yes, we have to be aware of certain complications that can be there when the cranial nerves get involved. And please remember why the cranial nerves get involved, because the cranial nerves will only get involved if the nucleus gets involved. Supranuclear, they do not get involved because there is bilateral representation. Importance of jaw jerk. Again, remember, jaw jerk, the cranial nerve we are testing is which cranial nerve? Which cranial nerve is jaw jerk? Fifth cranial nerve. So fifth cranial nerve. Now normally the jaw jerk is not elicitable, but if the jaw jerk is brisk, okay, the jaw jerk is brisk or it is exaggerated, it means there is an upper motor neuron lesion of the fifth nerve. We know the fifth cranial nerve nucleus is located in the, where is the fifth cranial nerve located?
Pons.
Upper part of pons. So UMN for that means it is above the pons. So when the jaw jerk is exaggerated, it means we have a lesion above the pons, either in the midbrain or the cortex or the internal capsule. Again, it also means it is not one-sided lesion, it has to be bilateral lesions. Only then the cranial nerve will get affected. So jaw jerk exaggerated means bilateral UMN lesion above the pons. The disease we call it as pseudo-bulbar palsy. Pseudo-bulbar palsy. It's nothing but UMN for the lower cranial nerve. That is what we mean by pseudo-bulbar palsy. Why persistent hiccups? Because of, I've told you, the nucleus that gets involved there, the NTS, the nucleus ambiguous, and also certain theories that you have something called as a Mollaret's triangle there, that gets involved. So persistent hiccups is a very important sign of lateral medullary. But please remember, hiccups can occur due to various other causes. You have to rule out other things also. It could occur due to uremia, hyponatremia. Okay, those things have to be ruled out. Emotional fibers in bulbar versus pseudofiber. Now, that's because of the facial nerve. So emotional fibers, emotional component is related to the facial nerve. So facial nerve, we say pons has the nucleus, which controls the various parts of the facial expression. But the emotional fibers are located in different parts. It could be located in the hippocampus, amygdala, frontal cortex. So these emotional fibers finally have to travel through the facial nerve, but their nucleus is not in the pons. Do you understand? The nucleus is not in the pons. Nucleus, they don't have nucleus. Emotional fibers are from multiple sides, but finally they travel through the facial nerve. So if you have a facial nerve involvement, LMN involvement, the emotional fibers are involved. But if you have a UMN involvement, upper motor type of facial nerve palsy, emotional fibers are spared because they are arising from different sources. So emotional fibers are difficult to emotional fibers are spared in case of UMN facial palsy. That means if you crack a joke, the patient will laugh. But if you ask him to laugh, he'll not be able to laugh. How do you check proprioception on the face? Proprioception you don't check. You check only vibration. That's what. And fine touch. That's the same pathway. There's no proprioception to be tested. What are the features of watershed infarct? Now, watershed infarct, they will not fit into any of the criteria. Depends upon where the watershed is. If it is in the ACA and MCA mid part, you may have hemiplegias. If it is in the occipital cortex, they may just have visual loss or hemianopias that could happen. Yeah, pseudobulbar palsy, this is what I just explained. Pseudobulbar palsy is bilateral UMN palsy, whereas bulbar palsy means LMN palsy. So the difference is pseudobulbar palsy, the patients will have emotional incontinence. That's a very characteristic. They'll spontaneously cry, spontaneously laugh. And very important, jaw jerk is exaggerated, gag is exaggerated. And it is bilateral pyramidal corticospinal tract involvement. So the patient will have bilateral exaggerated reflexes, bilateral extensor plantar. That is why it's called as pseudobulbar. And why is it called pseudobulbar? Because the patient has symptoms suggestive of lower cranial nerves, but it is not due to the cranial nerve involvement. It is because of the bilateral corticonuclear. So it behaves like the cranial nerve, but the cranial nerve nucleus is not involved. It is because of the corticonucleus. That's why it's called as pseudobulbar. Jaw jerk exaggerated is the feature of pseudobulbar palsy. That's the common question they ask you in your vivas. Any other questions or doubts?
Members,
clumsy hand syndrome with dysarthria. Can you explain
Okay.
about that?
There are lacunar infarcts. We were talking about all this thrombosis and embolism and hemorrhage on bigger areas, but small vessels can get blocked. We call it as lacunar infarcts. So these lacunar infarcts can occur at various parts. So it does not involve the entire medial. So it's a small structure like a posterior limb of the internal capsule can get involved, or basis pontis get involved. So it's a very small structure that is getting involved. So the entire pyramidal tract or entire cranial nerve will not get involved. So dysarthria clumsy hand syndrome is a type of lacunar infarcts which occurs due to the involvement either of the basis pontis or posterior limb of internal capsule. So they will not have any complete hemiplegia. They'll just have some amount of dysarthria, facial weakness because of that, or the cranial nerve involvement, and they'll have clumsiness in the hand. So it could occur due to thalamus involvement. It could occur in the nucleuses that are located there. So this is a part of lacunar infarct. So they will not have all the features of a full pyramidal tract involvement. Sometimes you can get the lacunar infarcts could be pure motor or pure sensory also, but dysarthria clumsy hand could be either in the basis pontis, posterior limb of internal capsule, or sometimes in the cerebellum also. What about involvement of vital centers in the medulla? Yes, if the medulla you have a big lesion that is there, it can cause death because of respiratory depression. Frontal eye field, etc. I think it's a long topic. I don't think so I'll be able to complete it in the small. When we, if at all, we discuss sometimes ophthalmoplegias, then we can discuss about frontal eye fields. Anything related to stroke?
Members, please feel free to ask any kind of doubts with sir. It was indeed a brilliant session, sir. Indeed, one of the best sessions we had in White Army so far. It was very nice to listen to your explanations and such sweet explanations, sir. Thank you so much. Members, feel free to ask any questions related to stroke today. Okay.
Mono versus.
So in pontine hemorrhage, why there is a hyperpyrexia?
Hyperpyrexia.
Pinpoint pupil.
Yeah, pinpoint pupil is because of Horner syndrome. Okay, pontine hemorrhage, Horner's has meiosis. So the patient has pinpoint because of Horner's. The temperature set point, the hypothalamus and the control of the hypothalamus is at that point there. That's why they have hypothermia. Venous thrombosis is a stroke. Venous thrombosis is a venous stroke. At that time I told CVT is not stroke. When I was speaking about stroke, I was speaking about arterial stroke only. Venous thrombosis also belongs to stroke, but does not fit into the classical definition of a arterial stroke. Mono versus diplegia. Again, remember, monoplegia is one arm only. Diplegia, the word diplegia means symmetrical structure involvement on either side of the body. Now, if I say facial diplegia means symmetrical involvement of the face on either side, or if I say diplegia for the body, classically described is for your cerebral palsy, where they have symmetrical involvement on either side of the body. That's when we mean diplegia. Hemiplegia is one side, mono is one limb only. Diplegia is symmetrical structure involvement on either side of the body. Okay, due to a cortical involvement. Diplegia is a word used only due to cortical involvement, specifically for cerebral palsy.
So
Any others?
lacunar stroke in internal capsule and difference between the whole internal capsule lenticular striate artery stroke. What is the difference?
Individual branches of the internal capsule. Again, remember, lenticular striate is not one branch. Lenticular striate is multiple branches are there in the lenticular striate. So just one lenticular striate branch getting blocked will not produce all the features. If all the features are there, that means it is multiple vessels getting involved, or it's a hemorrhage, which we discussed. These lacunar strokes involve only one of those branches, so they may just produce pure monoplegia only. They may not have sensory problem, they may not have facial, or they may have just dysarthria. They may not have other features could be there. So in the lacunar strokes, you'll have only one of the features, you'll not have all the other features that will be there. If the patient develop giddiness and vomiting at 5 p.m., then patient is stupor by the next day. Okay, so 5 p.m. it's hemorrhagic stroke most often, which produces this rapid deterioration of things like that. Okay, most likely it could be a cerebellar hemorrhage that could be there, which generally produces worst site of bleed is in the cerebellum, because it directly compresses on the fourth ventricle, and you have rapidly progressive raised intracranial tension, and the patient can go into coma. Evening occurrence of stroke is most often hemorrhagic or embolic strokes. It's unlikely to be thrombosis. Okay. So stroke in evolution versus progressive stroke. Stroke in evolution, both these words are no longer there. Stroke in evolution is nothing but thrombotic stroke. Okay, thrombotic stroke, where the deficit is progressing.
So in morning the stroke and MI are more common. Is it due to the sympathetic surge or
no?
Due to the
it's because of the prothrombotic state. Remember, the clot which is formed should get lysed, isn't it? So that requires a fibrinolytic system. And fibrinolysis starts with what? What starts fibrinolysis? How does fibrinolysis start? How does the fibrinolysis start? What is the first factor that is required there?
Plasmin.
Plasmin, yes, plasminogen should get activated. So the plasminogen should get activated. That will convert into plasmin, and then the fibrin breakdown happens. So now this plasminogen to get activated, you require a factor called as the tissue plasminogen activator, TPA. You heard of it? And in the stroke also, in acute strokes, we give, isn't it? We give, what do we give for acute stroke?
RTPA.
RTPA, isn't it? Recombinant tissue plasminogen activator. So that is the key factor that is there, tissue plasminogen activator. Now, the function of the tissue plasminogen activator is governed by one more factor. I think in pathology you would have learned, which is produced at the endothelium, called as PAI. What is the full form of PAI?
Protease activator inhibitor.
You're coining a new term. We're talking about plasminogen, so it's called as plasminogen activator inhibitor. So that is produced at the endothelium. Plasminogen activator inhibitor is produced in the endothelium, and the function of the plasminogen activator inhibitor is to inhibit the plasminogen. So if a stroke has to happen, if the thrombosis has to happen, what should happen? The plasminogen activity should be suppressed, isn't it? Plasminogen activity has to be suppressed. Only then the clot will form. So at 4 a.m. in the morning, the plasminogen activator inhibitor levels are high. And that is why even if you go to sleep at 10 o'clock, there is stasis and all those things, at 4 a.m. in morning, that is where the plasminogen activator inhibitor levels activity is high. And as you age, why do you get MI at older age? Why do you get stroke at older age? It's because of this endothelial dysfunction. More the endothelial dysfunction, more is the activity of plasminogen activator inhibitor. And that is where the fibrinolysis will not happen. And that's why stroke happens early in the morning. Yeah, the other factors are always there. Stasis is there, hypercoagulability is there. Endothelial injury can occur anytime. But this is the proposed mechanism why you get strokes in early morning hours, thrombotic strokes. Hope that was clear. Features of thalamic stroke. Features of thalamic stroke, they get something called as a Jerine syndrome. They have very severe burning dysesthesia on the side of stroke. They have burning pain they develop. That's a classical feature they get additionally. They have burning pain. Okay, it's called as Dejerine-Rossi syndrome. Any other question? How do you check Babinski bilateral? Below knee amputation is there. As far as you have the amputation stump, below knee means amputation stump is still there. You can stroke the amputation stump and look for the contraction of the tensor fascial lata. So tensor fascial lata is still there. So you can stroke the stump there and you can check it there. But if the amputation is above knee, then we can't check it in the lower limb. We'll have to look for Babinski equivalent in the upper limb. So you have something called as a Babinski equivalence in the upper limb. You have your Hoffman sign, you have the Tromner's sign. So those are the things that you see in case of, you can check if the lower limbs is amputated above knee. If below knee, you can still stroke the stump and look for the iliotibial tract. Venous system thrombosis, how do you differentiate? Again, the stroke producing due to, again, remember the venous thrombosis, CVT, etc. generally produces a diffuse focal deficits, a little rare in there. They come with encephalitis sort of features. They have headache, they have seizures, etc. And it does not fit into a vascular territory. The deficit does not fit into a vascular territory. So that's why I told venous stroke is a total different feature compared to an arterial thrombosis. So they will not have all the features like a particular arterial territory which is getting blocked. Any other questions?
So if a patient comes with well-controlled hypertension with hemiparesis, then what would be the location of the stroke?
Well, only hemiparesis?
Yes, sir.
Only hemiparesis, the most common location is internal capsule itself. Okay, the most common location is internal capsule itself. Either the facial nerve has recovered or the facial nerves will occur later. Most common location is always internal capsule only. Okay, hypertension, long-standing, you have something called as lipohyalinosis that happens there. The small vessels get involved, and any structure where there is a small vessels. So most common location would still be the internal capsule. Okay.
So would we consider it as a lacunar stroke then?
If pure motor, it is lacunar. Yeah. Again, please remember lacunar is based on the size when we do an MRI or you get the size. Okay. If on the CT or an MRI you get a big infarct, we can't say it is lacunar. Lacunar is based on the size that we get on the imaging. Okay.
So what is the difference between RIND and TIA?
RIND is a term which is, please remember, RIND is a term is outdated. Way back in 2003, that word was removed. Okay, RIND is no longer there, but yes, you should know RIND means the deficit is progressing for a week, whereas TIA recovers within 24 hours. And the latest definition that we have, November 2020, TIA, the definition says it has to recover within 1 hour. Okay, the deficit should recover within 1 hour, and more importantly, on imaging of the brain, spinal cord, or retina, you should not find any infarcts. So to define TIA, there should be a focal deficit which completely recovers within, earlier we were calling it as 24 hours, now we say it's 1 hour, but the imaging should be totally normal. There should not be an infarct. If you find an infarct, it is stroke. Okay, now all the definitions have been revised and they define it anatomically based on an MRI or a scans. If there is an infarct, that becomes stroke. Even if it is 1 hour recovered, it becomes stroke. So TIA is within 24 hours, the traditional definition. New definition says 1 hour, but there should not be any infarct on MRI. RIND was the deficit which was progressing up to 7 days. That term is no longer used.
About the CT scan and MRI difference. Now recently it is said that diffusion weighted MRI should be done first.
Diffusion weighted MRI is the gold standard test that we have. Yes. That is the one
we normally do CT scan, and CT scan is not that appreciable.
CT scan is done very fast. CT scan you can get it done within 5 minutes. Why do we do a CT scan is to rule out a bleed, because the basic difference in treatment of stroke is between a hemorrhagic stroke and an infarct. Hemorrhagic stroke we'll have to start on anti-edema measures, etc. Whereas an infarct we'll have to start on antiplatelets, anticoagulants, and we'll have to thrombolyze. So CT is done very rapidly. Very important. CT gets done within 5 minutes, and you can get the report and rule out a bleed. But infarct, look on a CT. A plain CT would take 6 to 8 hours for it to appear. So if you wait for a CT change to happen, it will, the golden period, that is the 3 hours that you have for thrombolysis, is gone. So MRI is best, and still best MRI is what we call it as a diffusion weighted MRI. Again, that would take a minimum of 30 to 45 minutes. Okay, so if the patient comes really early, you can do a diffusion weighted MRI, and within 3 hours we can thrombolyze. Target BP. Yeah, tell me.
So hemorrhagic stroke patient will say complain about headache or not?
Most often they will have headache. Yeah, most often they'll have headache. Yes, headache as a feature prior to the stroke and afterwards is a very important sign of hemorrhagic strokes. Yes, agreed. Target BP in ischemic stroke. Please remember, in ischemia we should not lower the BP. Even if it is above 200, you should not lower it in ischemic strokes, because that is the region surrounding the ischemic area, what we call it as the ischemic penumbra. The blood supply to that, the vascularity to that is maintained by a pressure head. So if inadvertently, if you lower the BP, you're going to cause more damage for the ischemic area. So unless we are planning thrombolysis, we have a cutoff of 180. You have to have a blood pressure less than 180. Otherwise, you can't have thrombolysis, because otherwise hemorrhagic conversion is high. Only then we'll give them antihypertensive. Otherwise, in an acute stroke, even the BP is more than 200, you will not correct it at least for the first 12 hours, because this hypertension is called as a reactionary hypertension. To preserve the ischemic penumbra, this BP is raised. So unless it is a you're planning for thrombolysis, you don't have to get it down. But yes, there are certain absolute indications, like a intracerebral hemorrhage, you will have to get it down immediately. If the patient has renal failure, or he has an aortic dissection, or a pulmonary edema, then we'll have to decrease it immediately. Stroke mimics, again, a very common question they ask you in your vivas: what are the stroke mimics? You have structural stroke mimics and functional stroke mimics. Structural means there is some problem, but it is not stroke. And functional is where there is no problem and it is. So common functional ones are like migraine. You have hemiplegic migraine, hypoglycemia, and sometimes hyperglycemia. Hyperglycemia can also produce stroke. Other electrolyte disturbances can also produce stroke. Epilepsy or a seizure can produce something called as a Todd's paralysis. After it may last for 48 hours, sometimes a week also it might last. So you can have Todd's paralysis. You can have tumors which can manifest acutely as a stroke, or you can have a space occupying lesion coming as a stroke. So these are the mimics of stroke. Okay, common ones, you have to rule out them. And you have psychogenic. Patient can mimic that, feels that he wants to gain something, so he might mimic stroke. So that's called as a functional hemiplegia. Stuttering hemiplegia, again, this was a term used, we do not have it anymore. Stuttering hemiplegia is where it's a frequent TIAs coming. Supposedly you have different TIAs coming within a span of a few hours. It comes and goes, comes and goes, comes and goes. It heralds stroke in the next 24 hours. The patient will go into a completed stroke in the next 24 hours. Again, these words are all obsolete. Stuttering hemiplegia, stroke in evolution, all those things are nothing. Now presently you have all functional definitions that are there. But yes, these can be asked in your exam, so you should be able to answer that. Any other questions? If there's nothing about stroke, then maybe if you have time, you can ask. Otherwise, I think we already crossed 2 hours. Yeah, what do you want to ask about liver? Yeah, you can ask.
Mr. MacBook, you can unmute yourself and ask. Okay, sir, directly. Instead of typing. Sir, they will keep asking the whole night, sir. Because if you keep explaining so nicely, it's a good opportunity for them, sir, to clear their doubts. But yeah, we'll have a separate session on important topics of gastro as well by sir. Week by week, sir has agreed to take us classes on important topics anyway. So I think today we had a very extensive discussion on stroke.
Yeah.
I think it was very sir explained in a very simplified manner, in a very understandable manner. Even a student like me, very average student like me, could understand the most of it. So sir, thank you so much. We are really delighted to have a class like this, sir.
Thank you.
In fact,
Thank you.
on behalf of all the White Army members, I should say, admit that this is one of the best class we had in the White Army so far.
Thank
Really,
you.
sir,
Thank
really. And we are really grateful to you for taking such valuable classes for us and making the studies more and more interesting, sir. We are worried if everyone will be taking up medicine only next, listening to your class.
It would be nice. I would not mind more cardiologists rather than cardiothoracic people.
Why, sir?
No, I'm saying more medical people.
Okay,
That
sir.
would be always nice.
Yeah.
Anyways, medicine is needed for
Yeah,
all the
and
subjects.
yes, sir. And definitely
Medicine
they
is
will
needed for all
carry
the
forward your
subjects.
legacy, sir. Your knowledge, whatever you're sharing, they'll carry it forward. Yeah.
Yeah.
And
Thank you.
I don't know, sir, how to thank you. Really, you have been a constant source of motivation for us and also a constant source of energy for our White Army. You have been one of the best mentors we have. So we don't have words. You are our own, sir. So
No problems.
I
No
don't
problems. No problems.
think
It's
we should
okay.
thank you. In fact, okay,
Yeah,
it's yours.
yeah,
White
that's
Army is
fine.
yours, all yours. So, sir, you take this platform to teach the students the best of yours, sir. And we
Fine,
are really
fine,
indeed
fine.
honored, privileged, and grateful to you for all your teachings and valuable time you spend on weekends for us. Thank you so much, sir. If possible, sir,
Thank you.
we'll have a medicine
I'll
quiz by
let
you.
you know. I'll let you know because I'll let you know the schedules, whatever it is. Okay.
Yes, sir. Yes.
Fine. Okay.
And, thank you so much for all the
Thank you.
activity.
Thank you.
Today the participation was also very good. The students
Okay.
were very enthusiastically participated and cleared most of their
Hopefully,
doubts.
yeah. Hopefully, their doubts are clear. They
Yes,
will
sir.
be
Yes, sir.
able to localize disease better when they see the next patient in the
Yeah,
ward.
and request is members use this video to revise. Okay, as and when you require, you can use these videos to revise for yourself and remember better. Okay, so thank you one and all for all your for all the participation. Thanks, special thanks to sir for making the best use of this evening. Thank you so much.
Okay. Thank you.